this patient was something different. She was a young medical student in one of the states in North India, and she had typical symptoms of tuberculosis. Chest X-ray showed left upper lobe cavity, and sputum. After the sputum examination, she was commenced on standard 4-drug TB treatment. For some reason, her symptoms continued to worsen, and the repeat sputum also was positive. They suspected drug resistant. They tested for the gene expert. It was rifampicin sensitive. They did the additional test for drug resistance. She continued to be drug sensitive, but her symptoms continued to worsen, and the subsequent imaging showed that her new lesions have started appearing in the other side, the right side. And that's when it was initially discussed, and then they decided to do therapeutic drug monitoring for tuberculosis drugs. And it was a big hassle to do it because the state in which she was residing did not have it. She had to be brought to Delhi, and even in Delhi has now, the National Institute of Tuberculosis and Respiratory Disease has now this facility. But couple of years back, they also didn't have the facility, and they had to ship the samples to Chennai in the NIRT, National Institute of Respiratory Diseases, Chennai, to do the drug levels. And they had to coordinate with the flight. The cold chain has to be maintained for the shifting of the samples, and it was a big hassle. Okay, so for this patient, they managed to do it. The values came as 0 for all the drugs they tested. They scratched their head and thought maybe there was a lab error or sampling error, we should repeat it. Repeat sample, all the drugs were 0. Something else is happening. They suspected the TB drugs which is being given is not getting absorbed, and then they changed over to all IV TB drugs, which are very few. We have only aminoglycosides, quinolones, and then linezolid, which we can give IV. But they have to do that, and then subsequently over a period of time, she symptomatically responded, sputum became negative, and she is now doing well. So why I wanted to, and further evaluation for malabsorptions is being done. So why I wanted to highlight is the importance of therapeutic drug monitoring, except because this was done, we could identify the reason why this patient, this medical student, was not responding to TB treatment. Multiple times we heard one size does not fit all patients with tuberculosis. Both suboptimal drug exposure and supratherapeutic concentrations are harmful. This is one study done in Delhi, in which they did TDM in patients with tuberculosis, 75 patients, and they found it, majority of the patients, 85 of them had at least one of the drugs below the therapeutic level. And in those with low therapeutic level, they did modify the drug regimen, but only half of the patients came back to them for follow-up and to ensure that the levels have been reached. That suggests how difficult it is in the programmatic situations to follow up to make do repeat TDM. And then in those with came for follow up, when they repeated the TDM, all of them had achieved the therapeutic range. We have until now analyzed 86 patients on first line TB drugs, and we found out that half of them, 53 of them, had at least one of the drugs below the target therapeutic level. INH 28, rifampicin 16. And rest of the drugs, as well as the combination of drugs which are below therapeutic level, is low. So most of the patients somehow get through the treatment successfully, because out of the 4 drugs, at least 2 or 3 of them have their levels achieved. Although one of them or couple of them are below the target level, it is low. So because that's the strength of our multi-drug treatment for tuberculosis. If one of them fails, at least if the rest 3 of them are there and achieving the therapeutic level, the treatment is being successful. Again, 600 milligram of rifampicin in normally weighing individuals is the standard of care for treatment of tuberculosis. So how did we reach the 600 milligram dose? It was based on pharmacokinetic argument because 600 milligram dose achieves serum drug concentration which is above the MIC of rifampicin. And also the higher dose, there was fear that adverse events will be more. As well as when rifampicin came into the market, it was highly costly. So government could not afford rifampicin. So the least possible dose, which is above the MIC, which will reach the level above MIC, was decided as the dose of rifampicin. But however, subsequent studies have shown that the 600 milligram dose is at the lower end of dose response curve. So maybe this is not sufficient. And also the rifampicin, the cost has dramatically come down, and there is no strong evidence that higher dose of rifampicin has increased toxicity per se. So we have to think that maybe what we have been following all these years may not be true. And this is a systematic review and meta-analysis. And we looked at all the literature, studies which have gone into the therapeutic drug monitoring in tuberculosis. And as you can see, the good quality studies like case control or randomized controlled studies were very few. And this is the currently recommended target peak concentration of all these drugs. And they looked at these drugs and what is the outcome of the patients, the clinical outcome, the response to TB treatment. INH, the relative risk of good response is 1.32 if the patient achieves the target therapeutic concentration. But again, if you can see, the confidence interval is crossing 1. Rifampicin, there is stronger evidence. It is just touching 1, relative risk of 1.4 for good outcome if it falls into the target range. Pyrazinamide has the strongest evidence that if you achieve target range, the clinical outcomes are best. And ethambutol, it is on both sides. According to this literature synthesis, there is not much point of achieving target concentration according to the standard what is being followed earlier. It doesn't reflect in clinical outcomes. So what I am trying to say that the earlier targets set years back, decades back, may not be actually applicable. We need to have new information, pharmacokinetic and pharmacodynamic information and studies to achieve maybe a higher dose may be better for our patients with tuberculosis. So what are the indications of TDM in tuberculosis? HIV infected patients, TDM will be helpful because of multiple factors. Because of risk of malabsorption, undiagnosed GI issues, bacterial overgrowth. It is indicated in HIV patients, patients with HIV, malnourished patients, and patients with diabetes. Because of autonomic neuropathy, the patients with diabetes can have diarrhea or constipation, delayed gastric emptying, and there is altered clearance of drugs and drug interactions. So we did a study. This was done by Deva, who was our MD student. He did as part of his thesis along with our clinical pharmacology department, and study whether diabetics have a different drug levels of TB drugs as compared to non-diabetic. It was a small study of 28 patients, and the plasma concentration of INH and rifampicin were measured over 7 hours. And we surprisingly, although literature-wise they said that diabetics have lower serum concentration of TB drugs, we found out that it is almost equal between the TB group as well as the non-TB group. The Cmax and area under the curve for both rifampicin and INH were almost equivalent. However, the clinical outcomes, symptomatic improvement, sputum conversion, radiological improvement, and weight gain were worse in those with diabetic patients. So, and when we looked at the risk factors for low drug concentration, diabetic status was not a risk factor for low drug concentration. Only BMI came one of the risk factors for both INH and rifampicin. However, we found a trend towards greater symptomatic improvement in those with higher drug levels. Although this is within the target range, the higher the drug levels, the better the symptomatic improvement, because the numbers were low, we could not achieve statistical significance. So in conclusion, pharmacokinetics of INH and rifampicin did not show much difference in our study with diabetic and non-diabetic, but diabetic had a poor clinical response irrespective of the drug levels. So probably this group needs a higher drug level within the target range so as to have a much better clinical outcome. The other indications of TDM include non-responsiveness for treatment, just like the case vignette I showed initially. On ATT not improving, we should consider TDM, as well as patients with impaired renal clearance and monitoring adherence to treatments. So this therapeutic drug monitoring is a big hassle. You have to bring the patient, draw samples at multiple time points over a period of a few hours. So, but it is difficult for the patients in the community. So is there an easier method of doing it? So for that, dried blood sample, dried blood spots taken in a special filter paper has been tried, and the advantage is minimally invasive. It is very easy. There is no need for cold chain for the blood to be transported, easy to transport, and many of the drugs has been found to be stable in the dried blood spot format, and it needs very minute quantity of blood. Dried plasma spot is another method which mitigates the effect of hematocrit and red cell partitioning. So here you need not correct for the hemoglobin because anyway they are removed from the plasma. So this is an ongoing study with which is just finished study by Dr. Samuel Santosh in clinical pharmacology. This is the paper is undergoing manuscript review, yet to be published. So the clinical pharmacology department were kind enough to share the data. So in which patients with tuberculosis, 61 patients with tuberculosis, rifampicin levels were assessed by dried plasma spots, and what they used was a Wattman grade 1 filter paper, which is a very low cost substitute. And they had a derivation cohort and validation cohort. 26% of the patients had suboptimal rifampicin blood levels. And when they compared it with the dried plasma spot, it has a lower concentration of a bias of minus 2.12. And you can use this correction equation to achieve the plasma rifampicin concentration based on the DPS spot sample values. And it has excellent intra-class correlation, 0.981. So this is very attractive thing in as compared to DBS, dried blood spot, to use the DPS. Only a disadvantage is that you need to centrifuge and separate the plasma, which is widely available in even smaller labs. So this is a concept in evolution, and hopefully there will be bright, it will have a bright future. What about other methods? Can we use hair for therapeutic drug monitoring? So this is a study from Chennai in which they used 30 strands of hair and they checked the drug levels in the hair. They used INH, acetyl INH metabolites in the hair, and they found out that if there is twofold increase in the hair acetyl INH concentration, there is outcome is better. There is less unfavorable outcome, less TB treatment failure. So hair is an attractive concept. Saliva is an attractive concept. Only thing is that in some of the drugs, there is the standard drug INH rifampicin, there is large variability of saliva to plasma or saliva to serum ratios. So there is much more work needs to be used before saliva can be used. Urine can be also used. There are studies which used urine. The target readiness level score for urine is 7. That means that 9 is the maximum score in which it is well studied. You can implement it in the community and it can be part of guidelines. So, but urine it is 7. It's just about there. Much more work needs to be done before we can use urine for therapeutic drug monitoring for tuberculosis. So, TDM in tuberculosis needs to be done, but lot more works needs to be also done. At the community level, how can the health workers screen patients, those who are at higher risk for low TDM? And then you need to have a regional as well as a central laboratory where the low drug levels can be confirmed and therapeutic adjustments can be done for the treatment. Pharmacogenetics is also important in tuberculosis. As some of you may know that INH, there are fast acetylators, slow acetylators, and based on that, the drug clearance, INH clearance can vary. And if you can detect the actual acetylator status of the patient, you can improve the outcome as well as reduce the side effects of the drugs. But this is a tedious process, and some people have tried the Gene Expert platform, which is a test which is done to rapid diagnosis of tuberculosis. Even COVID it was used, and they used this platform to find out the detect the NADG polymorphism in tuberculosis and to tailor the dose of INH based on that, whether they are fast acetylators or slow acetylators. So that is about tuberculosis. Now shift to the aspergillosis. So this is the patient which I saw a couple of weeks back. Right-sided destroyed lung because of tuberculosis in the past. Now this lady came with hemoptysis. And as you can see in the CT scan, there is a ball-like structure which is a aspergilloma with surrounding consolidations. So she has what is called chronic pulmonary aspergillosis. And we checked for aspergillus-specific IgG on the blood, which was highly elevated, and we commenced the patient on voriconazole. After 2 weeks of voriconazole, she came back. We checked the drug levels, the trough levels were low. So she didn't achieve that therapeutic target level, and so we have to increase the dose of voriconazole to achieve the maximum benefit. So I was privileged to be part of the International Society of Human and Animal Mycology, ABPA, Allergic Bronchopulmonary Aspergillosis Guidelines Group. So this was published last year. And when we analyzed the synthesis, we found out that we came up with the recommendation that itraconazole is almost as effective as steroids, which is the standard of care for treating a patient with allergic bronchopulmonary aspergillosis. But the issue with itraconazole is its drug absorption as well as the drug levels is haywire. This is a study which was published from my friends in Chandigarh, in PGI Chandigarh, and when they tested the itraconazole in patients with chronic pulmonary aspergillosis, and they compared between innovator and the generic brands. The innovator have 72% of them achieved the therapeutic drug levels, but in the generic forms, only 29% of them achieved the drug levels. So, and they also found out that those who achieve the therapeutic drug levels have better outcome, favorable outcome, even after adjusting for other parameters. And the dangerous thing is, on morphometric analysis, some of the generic brands had variable pellet numbers, sizes, and dummy pellets. So that is very dangerous for our patients if they are having itraconazole and thinking that it has some active ingredient, but if they are dummy pellets, how harmful it could be for the patients. So this is a small analysis which I did. So I'm grateful for our clinical pharmacology department because we introduced itraconazole drug levels only 1.5 years back, and we have been using it for our patients with aspergillosis. And this is an analysis. 28 times we had checked in 20 patients, ABPA 12 patients, and chronic pulmonary aspergillosis 8 patients. And in 50% of the time, the itraconazole level at the standard dose of 200 twice a day did not achieve therapeutic level, and we had to increase the dose. So the take-home message is TDM helps optimize drug dosing in respiratory diseases, particularly TB and fungal infections. Emerging sampling methods which are much more convenient and patient-friendly, like blood or plasma spots or hair levels, may be feasible in the future. More prospective studies are required to find out which is the optimal therapeutic drug levels, which has the maximum clinical benefit with least side effects. And there is a need for practical evidence-based guidelines for TDM implementation in respiratory diseases.